Assalamu alaikum doctors. In this video I am discussing a video stations that is pyloric stenosis. It recent come just 1 days back 2024. So the pyloric stenosis, so we know that it is a multifactor inheritance. Boys are more important than girls. 2 to 10 weeks of age it develop and run in families. The description should be like an infant or newborn baby in hospital setting. That is, if any device attached, IV cannula, anything, will pass comment. Then we'll tell mainly the importance to comment on the mass. There is a olive shaped mass, direction of the movement from left to right, and hydration status of the child. So there is a olive shaped mass and direction from left to right, and hydration status of the child. What is the differential diagnosis? That is pyloric stenosis, volvulus, intestinal obstruction, intestinal malrotation, gastroesophageal reflux disease, cow's milk protein intolerance, gastroenteritis with dehydration, and congenital adrenal hyperplasia if vomiting in the opening statement. So 2 or 3 DD we are telling. First of all, pyloric stenosis, volvulus, intestinal obstruction, cow's milk protein intolerance, intestinal malrotation. These are. What history? Suppose it is a case of pyloric stenosis. So targeting this and the DD, onset, course and durations, what increase and what decrease, usually gradually and progressively. Then vomiting. Vomiting, is it forceful? Hitting the wall. Onset of vomiting, if immediately after the meals. Color of vomitus, remember non-bilious. If it is green, then we call intestinal obstructions and its content. Then vomits after each feed. Is he hungry after feeds? Weight and height and comment on the growth chart. Number of the diapers changed per day. Any blood in the stool, type of milk and its amount in each feed, and no number of feeds per day. Family history of similar condition, as it is a multifactorial inheritance and more in males. Male and female ratio is 4:1. Antibiotic taken in neonatal period, erythromycin. Here onset, course and durations, what increase and what decrease. Then the vomiting, its descriptions. Then vomiting content. Is the vomiting just after feeding? Vomiting hitting projectile in nature, we know that, hitting the opposite wall. Then the child is after vomiting become hungry. Another is that what about child dehydration status? For that we know that how many nappy changing per day. Then we can ask about family history as multifactorial inheritance. Neonatal period taking any antibiotic or not, because erythromycin causes. Another are weight, height, growth chart. These are we are asking. Then examination, we know airway, breathing, circulation, dehydration status, and the shrunken hydration status. How can we know? Shrunken anterior fontanelle, skin turgor, shrunken eyes, dryness of the mouth, and number of tears. No tears. Feed test and check the response. General examination for any pigmentation, because congenital adrenal hyperplasia, so any pigmentation. Now investigation we done. First of all, full blood count and random blood sugar level, ABG and urea electrolyte. That is very important finding. Hyponatremic, hypochloremic, metabolic alkalosis. We can do abdominal ultrasound, more than 17 mm in diameter, length and thickness is more than 4 mm. X-ray of the barium shows sting sign or mushroom sign. So ultrasound abdomen more than 70 mm in diameter and thickness is more than 4 mm in diameter. X-ray with the barium, sting sign or mushroom sign. Now about the management of pyloric stenosis. I will admit the child, stop the oral intake, insert a NG tube and do aspiration hourly and test feed. IV fluid, if metabolic alkalosis, we are given 150 ml per kg per day of 0.9% sodium chloride plus 5% dextrose plus 10 millimole potassium chloride and repeat AVG every 12 hourly. If there is no metabolic alkalosis, I am giving 120 ml per kg per day of 0.9% sodium chloride plus 5% dextrose plus minus 10 millimole potassium chloride and AVG daily. Aim to fully correct the fluid and electrolytes within 48 hours. Chloride is more than 100 millimole per liter, bicarbonate less than 28 millimole per liter, and potassium more than 3.5 millimole per liter. Once where fully correction of achieved, convert to maintenance fluid 100 ml per kg per day. Surgery after correction of the dehydration and alkalosis, we do the Ramstead pyloromyotomy. It is an open surgery or laparoscopic pyloromyotomy. Feeding restarted after 6 to 12 hours and discharge within 48 hours if the patient is stable and tolerating feeds. Good prognosis. Team are my consultant pediatrician involving gastroenterologist involving pediatric surgeon anesthesia. Pyloric stenosis fluid calculation with medical student come on exam. So fluid at first we are giving 150 ml per kg. If metabolic alkalosis, when metabolic alkalosis not present, we are giving 120 ml per kg. And after electrolytes is when we correct, we giving 100 ml per kg. And then the surgery is Ramsted's pyloromyotomy. The prognosis, they ask, prognosis of the surgery is very, very good, because the child will be start feeding like after 6 to 12 hours, and discharge of the child 48 hours if the patient is stable and tolerating good pregnancies. At the beginning we tell that we keep him NPO, NGT feeding to all the secretion from the abdomen, IV fluid we give. And the team are my consultant pediatrician, gastroenterologist, pediatric surgeon and anesthesia. So this is all about pyloric stenosis video stations. So what happened, it is occur 2 to 8 weeks, remember, 2 to 8 weeks, not older child they will give. Another thing is that pyloric stenosis, what happened, there is hypertrophy of the circular and the longitudinal muscle of the pylorus. Look the picture, there is hypertrophy occur. And one thing important, pyloric stenosis, the vomiting content is not green. If it is green showing, remember intestinal obstructions. Thank you.